A recent macula-off retinal detachment requires treatment more urgently than a macula-on retinal detachment. So David first.
Okay. The conventional wisdom has always been that macula-on detachments are more urgent than macula-off. And I want to tell you that that's wrong. Now, it's always a little bit worrying coming and debating with colleagues in Greece, because I know that in Greece you've been honing the art of reasoned argument for over 2,000 years. But in Scotland, 2,000 years ago, we had our own way of developing reasoned argument, which we maintain to this day. So in order to prove to you that a recent macula-off detachment is more urgent than a macula-on detachment, I think I have to do two things. Firstly, I've got to show that macula-on detachments don't always need urgent surgery. And secondly, that recent macula-off detachments do need urgent surgery. So first thing is, do macula-on detachments always progress? And the fact is that a lot of them don't, and that those that do progress very slowly. This paper looked at 80 eyes with macula-on detachment. A lot of them showed no evidence of progression, and those that did progress, it was slow. The fluid advanced by about 1.8 disc diameters per day. Another paper looked at 200 eyes with macula-on detachment. 45% of them had had that macula-on detachment for at least a week before presentation. And the surgery was delayed by over 24 hours in, again, nearly half of them. Despite all of that, only one out of those 200 eyes progressed to a macula-off detachment. Tom Williamson and his colleagues in St. Thomas's Hospital looked at nearly 1,000 macula-on detachments that had come through over 14 years. And they found you could predict the ones that were at high risk of progression. And they were exclusively, or almost exclusively, eyes with predominantly supratemporal detachments. So if you've got a predominantly nasal or inferior detachment, you can be absolutely confident that is not going to progress. And even if it does progress, all of those eyes achieved 6/12 vision or better. Can we prevent progression of retinal detachment? Well, Jan van Meurs and his colleagues in Rotterdam have done some interesting work doing serial OCT examinations of patients with macula-on detachments and posturing them. And what they showed, they looked at nearly 100 patients that were postured on the side of the detachment, and when the patient got up to go to the toilet or have a meal, they did an OCT, and they showed that the detachment progressed during the interruptions at a rate of about 150 microns per hour towards the fovea. But if you postured the patient, you essentially stopped the progression. In fact, it regressed slightly. Here's an example from one patient. You can see on the right-hand side at the top, that's how the patient presented. They were postured for a while, and you can see that that fluid regresses. They get up and move around, have breakfast, the fluid recurs a bit. So by posturing, you can reduce any risk of progression, having already demonstrated that that risk is very small. How critical is the position? The answer is not very. Jan and his group went on to fit accelerometers to patient's head to measure the patient's position and the movement of the head. And they found that what caused the progression of the detachment wasn't so much the position or the posture of the patient, but head movement. If you move your head, then the detachment tends to progress. So you've got to get the patients to take bed rest and not move their head, and then the detachment is very unlikely to progress. So first question is, have I demonstrated that macula-on detachments don't always need urgent surgery? Firstly, they don't progress very fast, with the exception of a few supratemporal detachments. Even if they do progress, the results of treatment are very good indeed, and we can prevent progression by posturing the patient, minimizing head movement. So I think I've proven that, the first question. Second question was, do macula-off detachments need urgent repair? I think it's fairly widely agreed that patients with a long duration of macula-off detachment over a week do worse than those with a short duration. But it's less clear within that week whether urgent surgery makes a difference or not. And this is based on papers by Ross and others from the 20th century. looking at the duration of the macular detachment, and he said very clearly that providing you treat it within the first week doesn't really make any difference whether you do it at 1 day, 2 days, or 4 days. However, a few years ago, Van Bussel and other co-workers did a meta-analysis. And they looked at about 1,300 papers on retinal detachment outcomes. They found 9 that discussed visual acuity outcomes. And when they looked at that, they showed very clearly, as in this meta-analysis diagram, that you're much better off if you had your surgery within the first 3 days than if it was delayed to 4 to 7 days. There is a problem with this meta-analysis. It was exclusively scleral buckles. And as Lyndon was saying earlier this afternoon, over 90% of retinal detachments now are treated by vitrectomy. So we've got to think, is this applicable to vitrectomies? And for that, once again, we turn to the Beavers Uretina database. This now has data on over 7,000 retinal detachments. When looking at visual recovery, we're taking a rather smaller cohort of 2,000 eyes that were macula-off at presentation and were successfully reattached with 1 vitrectomy operation. And for these, we defined a good visual outcome as 6/18 or better. And if we divide these into quintiles by duration, so we've taken those 2,000 eyes and roughly 400 eyes in each of those bars, we see that there's a very significant difference between surgery in the first 3 days, 0, 1 or 2 days, compared to surgery at 3 or 4 days. And that difference then evens out a little bit after that. There's no difference between the 3rd and 4th quintile. The difference between the 2nd and 3rd quintile is only just significant. But this study is not randomized, and so there may well be confounding. There are lots of other things that influence visual outcome as well as the duration of the detachment, and I've listed some of them here. And the way to deal with that is when you've got 2,000 eyes, you can put that all into a logistic regression software and identify those things on multifactorial analysis that are significant independent risk factors for poor visual outcome. And we found 7 factors that were significant as independent risk factors. And unfortunately, most of them aren't modifiable. If you're older, then you're less likely to get a good visual outcome. If you're female, I'm afraid you're significantly less likely to get a good visual outcome. If you've got good vision to start with, you're more likely to have good vision in the end. If we look at the characteristics of the detachment itself, duration, again, is highly significant. PVR, if you've got PVR-C, you're less likely to get a good visual outcome. If you've got a total detachment, you're less likely to get a good visual outcome. And if you've got any copathology, you're less likely to get a good visual outcome. But of all of those, either gender, age, the PVR grade, total detachment, the only thing that's modifiable is the duration of visual loss. And so that's the thing we've got to concentrate on. If you want to improve visual outcomes after retinal detachment surgery, then early surgery is important. Well, you may say, well, that's just the Beavers Uretina database. Although there are a lot of numbers there, just one study. Is this an isolated finding? Tom Williamson, again, looked at 325 eyes, and he found, again, surgery within the first 3 days was more effective at restoring good vision than surgery later than that. Frings in Hamburg found much the same thing. Eyes treated up to 3 days with a better mean visual acuity than those treated later. And most recently, just in press, Margaret Greven from USA found exactly the same thing, that early surgery is associated with better visual outcome. Well, why does it make a difference? Well, there's evidence from OCT that you're less likely to have persistent damage to the outer retina if the retinal detachment is repaired very early compared to leaving it for a few days. So let's take 2 patients. They've got very straightforward standard retinal detachments. 75-year-old pseudophakic detachment, single superior tear, visual acuity of counting fingers. One of them, they both present on a Friday. One of them gets surgery on the Monday, and his chance of recovering 6/12 vision is about 63%. The other gets surgery over the weekend, and their chance of recovering 6/12 or better vision is over 75%. So a significant difference. It means that we should really be trying to get the retina reattached as soon as possible after a retinal detachment affects the macula. So recent macula-off detachments do need urgent surgery. We know that multiple factors affect the final visual acuity after successful repair of a macula-off detachment, but the only one that we can modify is the duration of detachment. Clinical evidence from the UK, from Europe, from North America, imaging evidence, big data, all of those combine to say the same thing, that surgery within the first 1 to 3 days is much better than surgery after that. So I have proven the second question as well. And when you cast your vote, do please remember Scottish reasoned argument. I know that Theo is very worried about this debate because he tried to poison me yesterday. He gave me this sort of white drink. It was clear water, and he poured something into it. And I'm pretty certain it was Dettol, potent disinfectant. So please, Chairman, don't let him poison me. Thank you very much.
I'll protect you. So